Hello everyone. Good morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome to week two of CPT Guideline Mastery Series. So let me know, Chorus, how do I sound? Am I audible? Thank you, Miss Mills, for letting me know. I can see Miss Mills is here. Catherine is here. Hi, Miss Linda. Who else are here? Miss Brenda. Hi, welcome everyone. So whether you're tuning in live or catching this recording later, I'm really glad you are here. I welcome you everyone. So today we are actually going to dive into a topic that might not have too much guidelines or complex guidelines in it. However, it's definitely a section you may come across your board exam. So it's important to understand these key concepts and coding rules. And today we'll be doing more scenarios and we will be going through those coding nuances. Okay, so let's begin our session. Hi, Leti. Hi, Toka. Welcome to the CPT Guideline Mastery Series. And first of all, let's not waste time. Let's begin by reading out the copyright. CPT Copyright 2026, American Medical Association, all right reserved. CPC is a registered trademark of AAPC. AAPC content found within this presentation is a copyright of AAPC. The keyword concept FTR, CHON, AMCI FAB 7, AMCI ICD 10 Slip Tab, and MCG are trademark of AMCI. The credentials CPC, CRC, COC, CPMA, CPV, CPCO are owned by AAPC. AMCI do not own right to these credentials. The credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA. AMCI do not own right to these credentials. Okay, I can see a few more people are joined. Hi, Steph. Welcome. Okay, is there going to be a cardio review by any chance? Yes, we'll be having cardiovascular system reviewed next week as well. And by the way, if you are looking for more topics, we are already having most of them covered in the playlist. So I will show you where the playlist is located. Hi, Renata. Welcome. Okay. So, yes, thank you, Ms. Mill. So, you can also let us know the topic which you want to or which you're looking forward to hear from us by filling out that survey form. By the way, I was going to talk about the survey form anyhow. So please code us. We have a lot of students during our live sessions, and I can see a lot of engagement in the chat as well. Even last week, I couldn't see too much submissions in the survey form. Okay, so kindly fill out that survey form and let us know whatever you want to ask, whatever questions you are having, and also let us know how these sessions are going, whether they are helping you, and please do fill out. It takes less than a minute, and that's all we ask. That's all we ask for. So your feedback really, really help us to improve and bring better sessions to you. Okay, so please make sure to fill out that survey form. You can, if you have any questions, you can fill them as well, and you can fill it towards end also. Okay, so today's topic, as I said, we are going to review the arthroscopy. Sorry, we are going to review, just go back, arthroscopy and the percutaneous vertebroplasty and vertebral augmentation section. Okay, that's the topic which we are going to review. And before we get started, let's take a quick look at where to find today's topic. So today's topic fall within the musculoskeletal system chapter, as you all know. And our first topic will be I think it's the second topic, but the percutaneous vertebroplasty and vertebral augmentation. It is found in the CPT code range 22510 through 22515. And our another topic would be endoscopy or arthroscopy, and it is found later in this chapter within the code range 29800 through 2 triple not triple nine 299 0.99. So it is found towards the end of your musculoskeletal system. Okay, now another important thing I want you to notice on the slide is the asterisk. Yeah, the asterisk next to the certain subsection heading. Whenever you see those asterisks, it tells us that subsection has special instruction or guidelines that are unique to that particular group of procedure. And that's one of the reason I thought I will take this topic today. So these special notes are usually presented before the procedural code listing. So always make sure you review them before selecting a code, and they contain important information about how the procedure should be reported. All right. Okay. Hi, Ramesh. Uh, hi, Taylor. Okay. So let's begin with the arthroscopy or endoscopy procedure. So, what is arthroscopy? Arthroscopy is a minimally invasive surgical procedure that is used to visualize, diagnose, and treat problem inside a joint. So, it's a type of an endoscopy procedure, and we got the term, or if we break down the word arthro, that means joint. All right, while scopy, that means visual examination using a scope. So that's how we got the term arthroscopy. That means simply looking inside a joint with a scope. So during the arthroscopy, surgeon will make a few incisions or portals, and an arthroscope is, which is a camera or a small camera, is inserted through the portal to visualize inside of the joint. And other surgical instruments can also be introduced during this time if necessary. If a surgical management is required, they might insert some surgical knife as well. So it becomes a surgical arthroscopy. So arthroscopy can be both diagnostic as well as surgical. All right, so arthroscopy can be performed on several joints, including the knee joint. You can see the image can be done on the ankle, it can be done on the shoulder, elbow, wrist, so and so. Okay, so it can be done on a lot of joints. Now, with that said, let's move on to the guideline part. Let's move on to the CPT coding guidelines. We have three important guidelines to remember, just three to remember while coding these arthroscopic procedures. Number one is key concept, that is surgical endoscopy or arthroscopy always include the diagnostic endoscopy or arthroscopic procedures. All right, so that's also a common guideline, right? Your diagnostic endoscopy is included in the surgical endoscopic procedure, and we do not report the diagnostic arthroscopic separately in addition to the surgical arthroscopy when it's done on the same session and also through the same scope. Okay, that's your golden rule number one. Okay, presentation does not fit into the screen. All right, so I believe you must be on the mobile version. So we have, yes, I can see the icon next to your comment. So you are currently in the mobile version of the stream. So if you can move on to the desktop version, we have a desktop version as well. I'll request the team to place a link on the chat so that you can see much a wider screen. All right. Okay, so let's move on to the rule number two, the golden rule number two regarding the cannula threshold. So during an arthroscopy, the removal of a loose or a foreign body is not automatically or separately reportable. So as I said, arthroscopic procedure can be surgical, can be diagnostic. During this arthroscopy procedure, it is also done to remove some of the loose body or some foreign body in your joint. So removal does not automatically or is not automatically separately reported. For it to qualify, the foreign body removed must be at least as large as the diameter of the arthroscopic cannula, and its removal must require additional access. So you can see this uh, image and example is given below for better understanding. So in scenario A, the fragment is smaller than the primary cannula, right? It's a small fragment or a small foreign body, so it can be removed routinely through the existing cannula. And that means the removal is not separately billable along with a diagnostic arthroscopic procedure. All right? And in scenario B, you can see the fragment is equal to or larger than the primary cannula. So if in such scenarios, surgeon will have to enlarge the portal or make a separate incision or even insert a larger cannula to remove the foreign body, right? Because it doesn't fit into the cannula. So in such scenarios, removing of the foreign body or removal of the foreign body may be reported separately. All right, so that's the criteria for reporting a foreign body or reporting a foreign body removal with the arthroscopic procedures. Okay, is that clear, coders? Let me know in the chat. All right. So yes, there is a link for the web version or the desktop version. So I hope that helps. All right, Chorus, let me know in the chat. I hope it the explanation helped. And the final or the third golden rule is that sometimes the arthroscopic procedure is performed, but during the same operative session, surgeon may also perform an arthrotomy procedure. So, what is an arthrotomy? Arthrotomy means surgically opening the joint through an incision. So, when an arthroscopy procedure and an arthrotomy procedure both are performed in conjunction, that means together, both procedures are separately reportable, and we report appropriate procedure code and append a 51 modifier to indicate that it's a multiple procedure. Okay, so that is your third rule, the golden rule number three. And as I said, arthroscopic procedure doesn't have too much guidelines associated with it. So these are only the three guidelines, and it's easy to remember, right? So let's go ahead. Next, do some exercise. Let's do some exercise. Before that, I will just show you the codes that falls under the uh, arthroscopic section, and as you can see, how these codes are organized. So in general, codes are classified first by the joint or anatomical site. You can see, for example, the codes for the temporomandibular joint. You have codes for the shoulder. You have codes for the elbow, knee, wrist, and all those joints. So within each joint, the codes are divided into two. One is your diagnostic endoscopy or arthroscopic codes. Second one is your surgical arthroscopic codes. So as I said, it can be done for a diagnostic purpose as well as a surgical purpose. All right. And diagnostic code describes just the examination of the joint, while the surgical codes describes specific procedures performed. So you have n number of procedures, surgical procedures that are performed using the arthroscopy, such as you have synovectomy, debridement procedures, removal foreign bodies, repair, and so other therapeutic procedures as well. So you can go through each of these codes. It's straightforward. Only thing is that make sure you read those parenthetical guidelines. See, so when coding arthroscopy, always identify the joint that was treated, whether the procedure was diagnostic or surgical, and exactly what surgical service was performed, and you will be good to go. Okay, so let's do some coding scenarios. All right. You have 2.5 minutes, by the way, to place your best answer in the chat. Of the following answers, which code best describe this procedure? Option A 29822, option B 29823, 29805 with a 51 modifier. Option C 29822, 29823 with a 51 modifier. Option D 29823. A 58-year-old patient undergoes arthroscopic surgery of right shoulder for persistent pain and mechanical symptom. During the procedure, surgeon performs debridement of the frayed tissue involving subacromial bursa, bicep tendon, and glenoid labrum. No other separately reportable arthroscopic procedure is performed. Of the following, which best describe this procedure? Alright, coders, go ahead and place your best. Yes, that's right, Miss Catholic. Place your best answer in the chat. All right, that's time. Is there anyone else to place answers? Please go ahead, place your best answers. Don't worry, no one is going to judge you here in this session or at the AMC. No one is going to judge you. Okay, so more you interact during these classes, better you understand and better or you remember them during the exams. Okay, so participate and be interactive. Okay, so great answers. I see a lot of wonderful answers in the chat. So let's go ahead and let's see what happened in this scenario. We have CPT code 29805, and that is coding for arthroscopic surgery, arthroscopic diagnostic with or without synovial biopsy. All right, and in our scenario, we had a surgical arthroscopy, right? Not a diagnostic arthroscopy. So as I said, there are two types of arthroscopic, surgical and diagnostic. So we had a surgical arthroscopic, and you can see a lot of procedures were done. So it's not a diagnostic arthroscopic. So I can eliminate the option that has CPT code 29805. That is option B. So you have to go option B. And then we have mainly two CPT codes, 29822 and 29823. So 29822 is coding for arthroscopic, so sorry, arthroscopy, shoulder, surgical, debridement, limited one or two discrete structures, while 29823 is coding for arthroscopy, surgical, debridement, extensive three or more discrete structures. So how many structures were involved in our scenario, or a debridement of how many structures was done? So let's count. We had subacromial bursa, biceps tendon, and glenoid labrum. So there are three discrete structures on which debridement was performed, right? And how did I know these were the structures that were outlined in the CPT code, or that were included in the CPT code? You can see they are included as an example next to the code language. You can see what all are included here. The humeral bone, humeral articular cartilage, glenoid bone, glenoid articular cartilage, biceps tendon, biceps anchor complex labrum, and you have, sorry, a anchor complex labrum, articular capsule, articular side of the rotator cuff, bursal side of the rotator cuff, subacromial, bursa, foreign body. So all these are the discrete structure that you can count. All right. So we had three, and those three were included in the example as well. And that's why I would say correct answer is going to be 29823. And that would be option D. All right. Let me know who all had an aha moment there. Type in the chat if you had an aha moment. And if you learn something, that's always priceless. That's what always Miss J says. So if you learn something, that is priceless. Okay, so let's move on to the next scenario. Here we go, exercise number 2. You guys are really rocking it. Okay, of the following answers, which code best describes the procedure? Option A, 29828, 29820. Option B, 29828, 29820 with a 51 modifier, 29805 with a 51 modifier. Option C, 29805, 29820 with a 51 modifier, 29828. A 62-year-old patient undergoes arthroscopic surgery of right shoulder for persistent pain and weakness. During the procedure, surgeon performs arthroscopic biceps tenodesis. The surgeon also performs diagnostic arthroscopy and removes inflamed synovial tissue with a partial synovectomy in the same shoulder. Of the following answers, which best describe this procedure? Go ahead, coders, your time begins now. All right, Curtis. Anyone else to please answer? I can see a lot of activities going on in the chat, the comment section. Okay, anyone else? Go ahead, go ahead. If you want to change the answer as well, go ahead. All right. All right. So let's have a look into this scenario. So what will happen here? We have a patient who underwent a arthroscopic biceps tenodesis procedure. All right. We had a synovectomy procedure as well. And you can see that surgeon also perform a diagnostic arthroscopic, right? A diagnostic arthroscopic and a synovectomy, and all was done on the same shoulder. So it's looked like there is three CPT procedures involved, or three procedures involved. That I'm sure about. So let's look at the codes. We have 29805, that is coding for arthroscopic shoulder diagnostic with or without synovial biopsy. Okay, so that is for your diagnostic arthroscopy of the shoulder. Then we have 29820, which is coding for a synovectomy partial. So that's a surgery, it's not a diagnostic one. So this one is for arthroscopic shoulder surgical partial synovectomy. And we have 29828, that is coding for a biceps tenodesis procedure as well. So these three CPT codes describes the three procedure performed here, right? So how can I arrive at the correct answer? So if I look at the parenthetical guideline here, it says that you cannot report 2928 29828 in conjunction with 29805, 29820, 29822. And if I carefully look, 29805, by the way, is coding for a diagnostic procedure. So if you have a diagnostic procedure and a surgical procedure, it's included, right? Your diagnostic scope is included into the surgical scopy. So definitely it should not be 29805. And with 29820 and 29828, you can see that you can only report 29828 and not 29820. So if you follow the parenthetical guideline, you can only code for one CPT 29828. And that's why I can see I saw a lot of people changing from option A to option C. So I understand that you got it there. Okay. So that's why I said these arthroscopy procedure section doesn't have too much guideline or too much complicated guidelines in it. There's some coding nuances, some parenthetical guidelines to follow. So if you just give a forensic approach or take a forensic approach or forensic look, I think you will be fine. Okay, so let's go ahead. Let's do one more. Exercise number 3. Of the following answers, which code best describe the procedure? Option A 29882, option B 29881, option C 29870, 2988159 modifier, option D 29880. A 30-year-old patient scheduled for diagnostic knee arthroscopic with persistent knee pain, swelling, and mechanical symptoms following sports-related injury. Under anesthesia, an arthroscope is introduced into the knee joint through the standard portals. A systematic inspection of the entire knee joint is performed, including evaluation of medial compartment, lateral compartment, intracondylar notch, and patellofemoral joint. Inspection reveals medial meniscus to be intact with no evidence of tearing. Examination of the lateral meniscus, however, demonstrate a complex tear with unstable fragments. Using arthroscopic instrument, the surgeon performs partial excision of lateral meniscus, removing the damaged tissue and smoothing the remaining meniscal edges. During the procedure, minor fraying of the articular cartilage is noted and in the same compartment and addressed with arthroscopic shaving, which is chondroplasty. The procedure is completed without complication. Of the following answers, which best describe the procedure? So, Codus, once again, if you put your forensic glasses on, you're going to easily crack the scenario. Okay, your time begins now, Codus. All the best. All right, Coda. So great, great answers. Great answers. Whoever has placed the answers in the chat. Excellent work, Codas. Excellent. Good job. I really appreciate the efforts you are putting in. All right. So let's have a look. This was a bit longer scenario, lengthier scenario, and you really had to put those forensic glasses on to solve this one. Okay. And let's have a look at the codes which we have here. We have 29880, which is coding for arthroscopic knee surgical with meniscectomy, medial and lateral, including meniscal shaving. So, looking at the scenario, I see that we had a meniscectomy performed, a diagnostic arthroscopic performed first, followed by a meniscectomy. So meniscectomy is a procedure which involves removal of the meniscus of the knee, and there are two meniscus here, medial and lateral meniscus. And during the inspection, it was revealed that the medial meniscus was intact. All right, it was doing good, and no evidence of tearing, while the lateral meniscus demonstrated complex tear. And using the arthroscopic surgical instrument, surgeon performed the excision of the lateral meniscus. So meniscectomy was only done on the lateral meniscus, not on the medial meniscus. So CPT code 29880 is coding for arthroscopic knee surgical with meniscectomy. medial, and lateral. So we only have to code for the lateral meniscectomy, not the medial, right? And that's why I would say 29880 option D is incorrect. Okay. And also, I see that yes, that's why we say option D is incorrect. Next, CPT code 29882 is coding for a meniscus repair. That's all right. So we didn't had a meniscus repair. We had an excision or removal of the meniscus, not a repair of the meniscus, which makes option A incorrect as well. We are left with option B and C. And option C is coding for 29870. All right. And 29870 is for arthroscopic knee diagnostic with or without synovial biopsy, and 29881 is coding for a arthroscopic knee surgical meniscectomy, medial or lateral. So it's medial or lateral. It can be either one. And in our scenario, it was lateral, right? And between B and C, why I would say option B is the right answer is because of this guideline, the guideline which I told you about in the beginning of the session. Surgical endoscopy or arthroscopy always include the diagnostic endoscopy, arthroscopy. All right, so the diagnostic endoscopy actually in this scenario is bundled, right? So that makes option C incorrect, and option B is the correct answer. All right, so I hope the explanation helped. And quickly, let's move on to the fourth exercise. Codus, I'll just begin the timer. Okay, you can start answering. Of the following answers, which could best describe the procedure? 29881, option B, 29881, 29874 with a 51 modifier, option C, 29881, 29874 with a 59 modifier, option D, 29874. A 46-year-old patient undergoes arthroscopic surgery of the right knee for pain management, pain and recurrent locking. During the procedure, surgeon performs arthroscopic partial medial meniscectomy. Separate large loose osteochondral body is also identified in the knee joint. The loose body is smaller than the diameter of the standard arthroscopic cannula and is removed easily through the existing cannula. Of the following answers, which best describe the procedure? Okay, coders, place your best answers in. All right, I know coders that I haven't given you full 2.5 minutes to solve or to answer the scenario because of the time constraint. I think we have got one more scenario, sorry, one more topic to cover. So I will just walk you through this one. Good job, everyone. Those who have placed your answers in the chat. Great answers. So over here we had a arthroscopic partial medial meniscectomy performed. All right. That's a procedure which was done, and also a large loose body or a loose osteochondral body was removed as well. And it is interesting. There's an interesting part in our scenario. The loose body is smaller. It's mentioned that loose body is smaller than the diameter of the standard arthroscopic cannula that is being used, and it is removed easily through the existing cannula. So that is a line which is going to determine the correct answer. Okay, so 29870 is coding for arthroscopic knee. Sorry, 29874 is coding for arthroscopic knee with removal of the foreign body, while 29888 is coding for arthroscopic surgical with meniscectomy, medial or lateral. We have medial meniscectomy. Now, of the all four answer, this guideline over here is really going to determine the correct answer. uh, okay, where it was. I'm just reading it. Okay, arthroscopic removal of the loose bodies or foreign body. And you have the CPT codes may be reported only or may be separately reported only when loose body or foreign bodies is equal to or larger than the diameter of the arthroscopic cannula used for specific procedure and only and can only be removed through the cannula that is larger than used for the specific procedure or through separate incision or through the portal that has been enlarged to allow removal of the loose body or foreign bodies. So in our scenario, the foreign body or the loose body was actually smaller than the cannula, right? The diameter of the cannula. So there was no separate incision, there were no enlargement of the portal, or no separate or no larger cannula used. It was removed easily through the existing cannula, which means that as per the guideline, you cannot report the loose body removal separately. And your only CPT code for this scenario would be 29881. Right? So once again, that is also a teachable moment. So this is another scenario based on the guidelines which we reviewed. I see you all did a good job, and if you learn something, once again, it's priceless. All right, so let us move on to the next topic. I hope you had a great learning from this section. Let's move on to the next one. Yes, so now that we have covered the arthroscopy, let's move to the percutaneous vertebroplasty and vertebral augmentation procedures. So before we again look into the individual procedure, let's understand why vertebroplasty or vertebral augmentation are performed. So these procedures are actually used to stabilize a weakened or fractured vertebral body, and especially when the vertebra has collapsed and is causing significant pain to the patient. So a common example is vertebral compression fracture, where the vertebral body becomes compressed and it loses its height. Or one another example or reason why this procedure performed would be osteoporosis, where the bones become weak and porous. Okay, so overall goal of these procedure is to strengthen and stabilize the affected vertebra and help to reduce the pain. Okay, so with that said, first look at the vertebroplasty procedure. So in a vertebroplasty procedure, actually what happens is that physician places a needle into the fractured vertebral body under the image guidance. So let's assume that patient comes with a fractured vertebra. The physician will place a needle into that fractured vertebra with the help of an image guidance, of course, and then injects a bony cement directly into the vertebra. So you can see a needle over here, it's inserted, and a bone, and then cement is injected through the needle, and this cement hardens inside the bone, and it further helps stabilize and strengthen the fractured vertebra. All right. So that's what happens in a vertebroplasty procedure. Now let's turn our attention to vertebral augmentation procedure. So this is also known as a kyphoplasty procedure. Kyphoplasty. So don't get confused if you see the term kyphoplasty in your scenario or in your exam questions. Okay, kyphoplasty means vertebral augmentation. And this is a little bit different from the vertebroplasty procedure. So in this procedure, physician actually creates the space or cavity inside the vertebral body. So you can see needle is inserted, and with the help of a balloon or something like that, the physician will create a space or a cavity, all right? And often by inserting and inflating a small balloon, the cavity is created with by inflating a balloon, and this can help to create room and restore some of the lost vertebral height. So if patient has a vertebral fracture, this will help to correct that lost height. And the balloon is then removed. Then bone cement is injected into the space to stabilize the vertebra. All right, that you can see over here in the step 3 and step 4. So this is the easiest way to remember. Okay, vertebroplasty means cement goes directly into the vertebra, and vertebral augmentation means a cavity is created first and then inject the cement. So this is main difference between a vertebroplasty and vertebral augmentation procedure. I hope the image really helped you to understand these two procedures, because it really helped me during my studies. Okay, so let's move on and let's look into the CPT coding of the vertebroplasty and vertebral augmentation procedure. So first is the vertebroplasty CPT codes, and it's reported with the codes 22510 through 22512. And the first code is a primary code 22510, and this is used for the first cervicothoracic vertebral body. While we have 22511, this is also a primary code, and it is used for the first lumbosacral vertebral body. Okay, and if additional vertebral bodies are treated during the same session, we use the add-on code 22512 for each additional level. So 22512 is an add-on code. And next we have the codes for vertebral augmentation procedures. So here the code is from 22513 to 22515, and 22513 is used for first thoracic vertebral body, and 22514 is used for the first lumbar vertebral body, and for each additional thoracic or vertebral body treated, we use the add-on code 22515. So we just have three codes for each of these procedures. Okay, and remember, coders, there's an important guideline you have to remember from this section. Use one primary procedure code, and then you have to use the add-on code for the additional levels. Okay, you can use only one primary procedure code. And the main difference here is that vertebral augmentation will include creation of the cavity using a mechanical device such as balloon followed by injection of the bone, while the other one is directly injecting the cement. Okay, so when choosing the code, first ask whether it's a vertebroplasty or augmentation. Then identify the spinal region and how many vertebral bodies were treated. Okay, so we have third section that is for a sacral region, and the coding is a little bit different here. So for sacral augmentation, or otherwise called a sacroplasty, It is reported using category 3 codes, which is a temporary codes, which is 0200T and 0201T. And here we don't code for each sacral level separately. Instead, the code selection is based on whether the injection is unilateral or bilateral. So for 0200T is reported when sacroplasty is performed unilaterally, meaning just one side of the sacrum, while 0201T is reported when it is performed bilaterally. Okay, so okay, so let's move on to the guideline, and these procedures include the bone biopsy. So bone biopsy procedures are not reported separately along with the vertebroplasty and vertebral augmentation. Next one is image guidance. We should not report the image guidance separately, they are also included. All right, and yes, so here is an overview of the CPT codes. First question ask you should ask is whether it's a vertebroplasty or augmentation. Second question to ask or to identify is the location of the procedure. All right, and how many levels were involved. Okay, also look into the guidelines, what are our bundle and your exclusion list as well. All right, with that, let's do one exercise from this section as well. Here we go. Here are your guideline question options. Of the following answers, which code best describe the procedure? Option A 22510, 22511, 22512. Option B 22510, 22512 times 2. Option C 22510, 22512 times 2, 20225 times 3, 77002 times 3, 22513, 22515. A 68-year-old female with severe debilitating back pain due to osteolytic compression fracture secondary to metastatic breast cancer presents for treatment. The medical team performs percutaneous vertebroplasty under fluoroscopic guidance to stabilize the fractures at T11, T12, and L4. Bone cement is successfully injected to reinforce the vertebral body, and bone biopsies are performed at all three levels. Of the following answers, which best describe this procedure? Coders, you've got 2.5 minutes. Take your time and place your best answers. So always have a look into those guidelines which we reviewed because you might have an aha moment here. All right. So I just want you all to give some time, and I put out that uh, small tip, and I see that you all are you grab that one, and I see your answers are changing. So good job. So it's this is what I said, learning moment. Okay, so let's have a look. So we had a percutaneous vertebroplasty procedure done, where the cement is directly injected to the vertebra, right? So we have it done on three places: T11, T12, and L4, two thoracic and one lumbar. So 22513, that's coding for a vertebral augmentation procedure. So we didn't had a augmentation, we had a percutaneous vertebroplasty procedure. So it's a different procedure that eliminates option D. And CPT code 22510 is coding for percutaneous vertebroplasty for cervicothoracic region. So yes, we had first one is thoracic, that is T11. So it covers cervicothoracic, so it's in from the thoracic region, right? So that's a good code for T11. And next we had for T12, and also we had a lumbar as well. So lumbar, the CPT code could have been 22511, which is for a lumbar percutaneous vertebroplasty lumbosacral. But here is a catch: the guideline. The guideline specifically stated that. Yes, that's why I believe you all changed the answers as well. Use one primary procedure code and add-on code for additional levels. So you can only use one primary procedure codes. So 22510 we have already used for the first T11, and then we are having T12 and L4. So you can only use one primary code, and the remaining you should use add-on codes. That's why option B would be wrong. Sorry, not B. Option, I would say C would be wrong. Also, not C. Option A would be wrong. Yeah, option A would be wrong. And also option C is incorrect because that's coding for a bone biopsy procedure. And again, the guideline over here says that bone biopsy is also included into these vertebroplasty and vertebral augmentation procedure. So no need to code the bone biopsy as well, and that eliminates option C. And your answer is going to be option B, 22510 for the cervicothoracic, 22512 times 2. That is for the additional levels, that is thoracic and lumbar. So you all did a great job, amazing job. I see a lot of people have changed answers, and yeah, I hope you really had that aha moment with this scenario, and you had a lot of teachable moments, right? Okay, so let's finish by doing some hand pulls, and it's a rapid fire. I have only a couple of them. Place your answers code. This is purely based on the guidelines which we learn. How should a percutaneous sacral augmentation or sacroplasty be reported when reporting or when treating multiple sacral vertebral bodies during the same session? How should these two placements reported? Option A, report primary code and use add-on code 22512 for each additional level. Option B, use 51 modifier with primary and primary code for each additional sacral level treated. Report appropriate sacral procedure code only once per encounter. Code each level as separate percutaneous vertebroplasty using 22511. Remember, coders, this is for sacral augmentation. Okay, sacral augmentation. You remember the final slide which I showed? Yes, absolutely. Yes. So you it's different. Sacral augmentation procedures are coded separately. It's different from the other levels or other regions. For sacral, report appropriate sacral procedure code that is from category 3, which is the temporary codes, and you should report only once, right? And the codes only changes depending whether they are unilateral or bilateral. Next one, a patient requires both arthroscopic procedure and open arthrotomy on the same joint during the same session. How should the arthroscopy be reported, code be reported. Use modify 59 to arthrotomy code. Use 52 with the arthrotomy. Use a modify 51 with the arthroscopy code. And arthroscopy is bundled and cannot be reported with an open procedure. What say you, coders? Okay, absolutely right. Yes. Add a modify 51 with the arthroscopic code. Okay, so those were the guidelines. I didn't build a scenario on them, so I thought like I'll put it on the handful so that you can just review it. Okay, there you go. There's the guideline. Arthroscopy is performed in conjunction with arthrotomy. Add a 51 modifier. All right, so coders, with that, I believe we come to a conclusion of the second week, and I hope this session helped you in case you need or you feel like you need more time or more practice. Don't worry, the playback is always available for you in our YouTube channel, and I'll show you where to find them. All you have to do is to go to AMCI channel, and there you go in the playlist which is called CPT Guideline Mastery. So you have a lot of topics. I believe last week we almost completed the integumentary topics. Almost we covered all the topics, and by this week also I believe we completed almost all the part of the musculoskeletal system. So that much resources are available for you in this playlist. So please go ahead and you can watch them. And also Miss Mills also have placed a survey link. Yes, please do fill out that survey form. I see a lot of people there in the chat responding to the scenarios, responding to us as well. Please do feel free to fill that survey form. Let us know which topic you are looking forward to for next session. I did so one topic for today's session on I think it was fixing uniplane or multiplane fixing. I hope we will be covering them during the next series. And Codus, as I said, if you have such topics or if some topics which we haven't covered yet, if you have them in mind, please mention that in the survey form, and we are happy to bring them to you. Also, let us know how we did. Okay. All right. So survey form is in the chat. With that, we come to a conclusion of the second week of CPT Guideline Mastery here at AMCI. If you really enjoyed this video, please smash that like button. Please smash that like button. And also subscribe to our AMCI YouTube channel. I can see that the community is growing bigger and bigger each week. So go ahead, subscribe to our AMCI channel. We have a lot of content in the YouTube's channel, a lot of live classes as well. So stay tuned. Click that bell icon so that you will get the notification whenever we go live with any topics, and share it with someone who really need to see this as well. So thank you, my team. Thank you, Miss Moose. Thank you, Miss Catherine, for helping me through the session. Thank you, team. Thank you, coders. See you all next week. Once again, please don't forget to fill out that survey form. Till then, stay safe, keep coding, and we'll be back next week with another topic.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI. 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 AMCI.